Next case from Shital.
All right, so he's a 5-year-old healthy male child, had a left distal femur fracture during a water slide, and was placed in a skin traction and then underwent close reduction and pinning and an above knee cast. So this is the x-ray. So few things here. One is that in a 5-year-old child with this fracture, if it's a closed injury, could you have treated it without surgery? Number one, I think so. 5-year-old, you can just put a cast on. Second is, if you pin it, do you think these are two pins or they are acting as one pin, because both of them are actually at the fracture site and they are both parallel. So it's one pin. So is there a need for the medial pin? Is it adding anything to the stability?
Yeah, Sandeep.
No, I think it's not at all. They're acting like one pin in the same direction, same trajectory probably, and not holding well. Intramedullary medial and risk of vascular.
Right. So this patient was treated. The patient was traveling, was treated in another country, and then came back. Because they live in Cincinnati, so they came back and saw us. But the history is that the parents noted discolored and cold toes. And then the surgeon examined the patient, split the cast, but did not remove it. So he thought it is too tight of a cast because there was discoloration of the toes. So he split the cast, and then the patient post-op day 4 is when we saw the patient. We did an arteriogram, and you can see the pin is right through the vessel there, or at least the vessel has no flow beyond that. You can see that, no flow there. So this is how the pin was going through the medial side. Okay. And this is how the limb was. Okay. So for something which probably the patient did not require any surgery, okay, and the patient ended up with an amputation. All right. So we have followed this patient long term, and I don't think I have to give too much of a talk here because it's explanatory that you need to be aware of where the vessels are. You cannot put a pin from the medial side of the thigh. That's an area that everyone knows. But if you look at it, we all know the anatomy, but if you look at iatrogenic arterial injuries, it's not that uncommon. Okay? The study of 252 patients who needed treatment for arterial injury, 85 iatrogenic injuries. Okay? So it's not like the trauma caused the injury. 85 iatrogenic arterial injuries, so it's not that uncommon. If you look at them, 23 were intraoperative. Now, tumor resections you can understand, but 5 were simple orthopedic procedures in this study. So they were arterial injuries from 5 orthopedic procedures. If you look at this arthroscopic survey, 6 vascular injuries during knee arthroscopy, all popliteal artery, and 4 amputations, okay, from arthroscopy. So nothing is benign. If you are treating these, especially the posterior horn of the lateral meniscus, the artery is just behind it. With all the newer implants, you have to be careful about the penetration, how deep you go with the sutures, because it's about 1 centimeter behind your meniscus. So if you get too deep, and similar with the PCL, there have been a lot of reports of arterial injuries with PCL reconstruction. So you have to be careful. Here, 68 iatrogenic arterial injuries with total hip arthroplasty, and all these are different reasons. 5 deaths and 10 amputations, okay, in this report during total hip. So I'm just giving you an overview of arterial injuries and the harm caused by them. So I won't go in details, but just a case to, get everyone alert.